So for progressive weakness, we want to make a differential list. This is our presenting symptom, and what we have is a bunch of possibilities. We can start in the motor cortex, and from the motor cortex you have all of the upper motor, so this includes upper motor neurons, all of them, and upper motor neurons go from the motor cortex all the way down to the anterior horn of the spinal cord. And at the anterior horn following, you have lower motor neurons, and so these two groups will present with different symptoms. First of all, if it's the motor cortex, if it's a lesion there, you would expect it to be unilateral. So unilateral. If you have bilateral weakness, you can almost always exclude the motor cortex. The other thing that you can have, so motor cortex, upper motor neuron tracts, lower motor neurons, you can also have myopathies. So, and now this is all for true weakness. You can also have pseudo weakness, which would be stuff like fatigue and stress, tiredness. Those kind of things are pseudo weaknesses, not true weaknesses. The first thing you want to do is distinguish if it's a true weakness or not. And there's some ways you can do that. If a person complains of just being weak, it's usually a pseudo weakness. But if they complain of specific events like brushing hair, walking upstairs, those are usually true weaknesses. So since we have, with our progressive weakness, we know that we have bilateral weakness that was presented in the case. And so since it's bilateral, let's go ahead and scratch off motor cortex. We haven't completely eliminated it, but for the most part we have. The next thing we want to do, can we scratch off anything else? So how do you distinguish upper motor neuron, lower motor neuron, and myopathy? And before I go into that, with myopathy, you might include the neuromuscular junction, because that's part of the pathway for motor movement. So the way we're going to do this, anything from here and below is going to have different symptoms for reflex. So if you remember, we'll take a look really quick. If we have our brain here, and then our spinal cord, and then our peripheral nerves from the anterior horn coming out, what happens is, if we take a look at the spinal cord in a section, so here's my spinal cord, and this is the anterior horn. These are where the lower motor neurons are going to start. The upper motor neuron is going to send two types of fibers in. So this type of fiber is going to be like a stimulating fiber, saying, why don't you go ahead and move? And then this fiber is going to be an inhibitory fiber. So we don't want you to move too much. So this fiber says, don't move too much. These are both upper motor neurons. And so if we get rid of these, we'll have a weakness or a paralysis, but we'll also have a lack of inhibition. So if we test for reflexes, the reflexes will be hyperreflexic. Hyperreflexia. And so the onset, you're going to get a flaccid paralysis, but after a few days, maybe up to a week, you're going to start getting hyperreflexia and spastic paralysis, spasticity. So that would be upper motor neurons. On the other hand, lower motor neurons, so let's put UMN, upper motor neurons. Lower motor neurons are going to have hyporeflexia and flaccid paralysis. In our case, we start to see some hyporeflexia. So let's go ahead and mark off upper motor neurons from our list. So upper motor neurons, we're going to rule those out. Now, it's going to be between lower motor neurons, neuromuscular junction, and myopathy. So let's go ahead and build up a differential. With lower motor neurons, these would be called peripheral neuropathy. And there's a bunch of different types of peripheral neuropathy. Specifically, at the level of the anterior horn, you have something called a radiculopathy. So radiculopathy means damage to the anterior horn of the spinal cord. Then you have polyneuropathy, which is anything below the level of the anterior horn, but it's not a single level. It's not just a single nerve. It's not just a single thing coming out of one anterior horn. It's multiple areas. And then you have mononeuropathy. This is sort of a simplified list, but this is a good enough list to get a great differential. I say it's simplified because you can have other things like polyradiculopathies and stuff like that. You can also have autonomic neuropathies, which we may talk about later. And lastly, you can have a special type of mononeuropathy where you have two consecutive. So mononeuropathy would be one single nerve fiber being damaged. This would be something you'd see like in carpal tunnel. But if you have two nerves consecutive to each other, it's not a polyneuropathy, but it can kind of look like one. It's really two mononeuropathies combined, so you got to keep that in mind as well. So let's build a differential list for polyneuropathy. Things that can cause polyneuropathy, you can use the mnemonic B stapled G, or GB stapled. I don't care which way you do it. But we have B vitamins, specifically B1, B6, B12. You can get sarcoidosis, which is the deposit of sarcoid tissue inside of your tissues. T, we want to look at ticks, tick diseases. A is for arsenic. P is for porphyria. L can have two meanings. It can be Lyme disease, which is another tick type of thing, or it can be leptomeningitis. You can see I've got E lowercase. It's just there to make the word work. D would be diabetes. Diabetes can cause a polyneuropathy, and you would call this a vasculitis. Vasculitis in general will cause polyneuropathy. G we're going to classify as Guillain-Barre Syndrome, GBS. And you can also think of glue, because the hexane in glue can cause a toxic polyneuropathy. So that would be our polyneuropathies just in general. The list is truncated, but it's a good list to start from. The next thing we'll look at would be things like radiculopathy. Guillain-Barre actually is classified as a polyradiculopathy, so just keep that in mind. Most of it presents like a polyneuropathy, but it can attack the anterior horn as well. Then we're going to say just polyneuropathies. We're going to just say spinal cord compression. We're not going to look at mononeuropathy. Mononeuropathy, the key is to look at myotomes and dermatomes. So if you can say that this doesn't follow a specific myotome or a specific duratome, then it's probably not a mononeuropathy. Then at the neuromuscular junction, we're going to use the mnemonic LAM. So LAM, we'll make that a lowercase. It's just there to make the word work. But LAM, we have Lambert-Eaton myasthenic syndrome, just often called Lambert-Eaton. Then we have myasthenia gravis. And finally, botulism. With Lambert-Eaton, you can do a really simple test called the grip test, and what you'll have a person do is repeatedly grab your hand and squeeze it over and over again rapidly, as fast as they can, and if their grip gets stronger each time, means it's the opposite of fatigue, then that strongly rules in Lambert-Eaton. On the other hand, with myasthenia gravis, usually people will present with ptosis in their eyes, and so you can do something called the ice pack test. And if you put ice over their eyes and it gets better, then that would rule up myasthenia gravis. And you could follow that up with a Tinslin test. I'll go over both of these mechanisms in a future super objective on myasthenia gravis. Botulism, on the other hand, is one of the world's most potent, it is the world's most potent toxin. It takes 1 nanogram to basically kill you. The second most potent toxin would be tetanus, and it takes about 1.5 to 2 nanograms of the tetanospasm toxin to kill you. So let's assume we went ahead and did these tests and we ruled these out. We still have myopathies to deal with, and so our list for myopathies, we would have things like polymyositis or dermatomyositis, I'll just put DM, rhabdomyolysis, I'll just put rhabdo. Now these two are autoimmune diseases. This is basically a disease where your muscles just break open and start spilling all their contents out into your blood. And so you could test for this really quickly by doing some blood work. The number one cause of rhabdo is overexercise. So there's that, and if we can just check in our patient history, if there's no extensive exercise, we do some blood work, we can rule that out. Also, we can run some autoimmune panels for, I think, anti-Jo1 and the PMDM antibodies, and we can rule those out as well. There's a few other diseases that don't really fall well into a specific category. The first one would be amyotrophic lateral sclerosis. This presents with both upper motor neuron and lower motor neuron symptoms. And it has to do with basically like glutamate excitotoxicity destroying some neurons. And there are other mechanisms of oxidation and stuff like that that's involved as well. We'll go ahead and put multiple sclerosis, MS, and Wilson's disease. Wilson's disease is basically a failure of your body to metabolize copper. Copper is with an E. And the way you test for this is with ceruloplasm. Ceruloplasm. Now with MS, what you're looking for is symptoms that seem to maybe come and then regress a little bit, and they can even start in one area of the body and move to another area of the body. And so you may get weakness, you may get sort of a craziness, different stuff going on. It's going to affect the central nervous system, but it affects all the way down through the spinal cord and everything. And so if you see the main hallmark is that the symptoms kind of progress and then regress, and it's sort of a slow forward marching and backward marching. And so if we don't see that, it would take years to see that, and we want to find out what this is before we get to that point. So right now we've got our list down to basically these polyneuropathies right here, and we want to get a good patient history and see if we can't figure out what it is exactly. Now in your patient history, you find out that your patient, they have schizophrenia, they have bipolar disorder, they have systemic lupus erythematous, and they also have seizures and psychosis. So psychosis would fall under schizophrenia. And with all these diseases, or this, I don't want to call them diseases, but with all these mental problems, disorders, there's also going to be quite a bit of pharmacy involved. And I didn't put all that pharmacy on here. I have them all under Quizlet if you want to go there, Block 3 Pharmacology. But anyhow, one of the things we're going to worry about is whether or not the medicine's being taken properly, whether or not there may be some toxic side effects from taking too much. And so one of the things you're going to do when you see polypharmacy is you're going to test for the drug levels in the blood and in the urine. If those all come back normal or within a decently normal range, then you're going to keep moving on. So now let's run a bunch of tests. Let's rule out Wilson's disease with ceruloplasmin. Remember, Wilson's disease is a disease of copper metabolism, and ceruloplasmin is used to carry copper. Whenever you have Wilson's disease, you'll have a reduced ceruloplasm. B vitamins, we want to make sure those are all okay, especially I would say B1, B6, B12, especially B1, however, and that would be thiamine. And then acetylcholinesterase, what is this? This is, again, we're at the neuromuscular junction, and we're checking for Guillain-Barre. And what Guillain-Barre is, if we have our nerve, our motor end plate right here, and here's our muscle. Here's our muscle. And we have let's zoom in a little bit. We have receptors right here to accept acetylcholine. And so here's our acetylcholine. It's packaged up in a vesicle, and then it gets sent out of the vesicle whenever the calcium channel is open from depolarization and say, let's get you out of here. And then they'll come down here and bind. And actually, they'll only two will bind per receptor. So each receptor will bind 2 acetylcholines. And whenever they bind, they'll open up and allow depolarization. So it'll depolarize to -60 at the motor end plate. That's called the end plate potential. And that will allow the muscle to then fire off its action potential and depolarize and contract. After that happens, we have, let's draw a pair of scissors here. So these scissors will come in and clip up the acetylcholine into acetate and choline. And that will be taken back up into the neuron so that it can reform acetylcholine. With myasthenia gravis, what happens is you'll get antibodies that will form and block these receptors. Not all of them will be blocked, but many of them will be blocked, and so you don't have as many acetylcholine receptors for the acetylcholine to act upon, and so it takes a little bit longer to depolarize to -60. And it never gets there because all the acetylcholine is being cut up. So if you use an acetylcholine esterase inhibitor, you can actually treat that disease. But what we want to do is check for these antibodies. And if those antibodies are there, that would indicate that this would be myasthenia gravis rather than anything else. And so we would look at both the ability of acetylcholinesterase to bind acetylcholine. We'd also look at the acetylcholine blocking antibodies. So then on the antibody panel, we want to rule out things like polymyositis, dermatomyositis, any type of myositis, and anything that could affect any of the nerves in the pathway. Something we can look and see if the SLE is under control. And when we do, we find out all these things are the SLE is under control, and none of these things are really a problem. And you do an MRI. Why do an MRI? Well, there's a couple of reasons. First of all, you just want to look at the overall gross structure of the brain. But also, if you want to do a lumbar puncture, which is on our list of things to do, you want to make sure there's no hydrocephalus. So hydrocephalus is increased intracranial pressure due to the cerebrospinal fluid. And if you have a high cerebrospinal fluid, doing a lumbar puncture could allow the brain, like the pressure from the cerebrospinal fluid would push the brain down into the foramen magnum in the skull, and you cause a lot of problems, a lot of damage. So one of the things you'll do on an MRI is you'll look at the size of the ventricles. You can do this on a CT too, but according to Radiopedia, the MRI is just a better way to go. One thing that was noted on the MRI is hypo and hyper densities. Hypo and hyper densities, and I'm not going to go into that because I don't have any good pictures to post up, and I don't think it's particularly high yield. Now when we do the lumbar puncture, what exactly are we looking for? So the first thing we're going to check is we're going to look for infection. We're going to look for evidence of hemorrhage. And also we can look for evidence of MS, multiple sclerosis, and Guillain-Barre syndrome. Now you should be aware that if you see red blood cells in a lumbar puncture, that doesn't particularly mean anything because you're going to get some red blood cells. You'll probably get way more red blood cells than the actual limit just from the puncture itself, because most people just aren't really great at doing this. Someone supremely skilled is going to get a really low number of red blood cells, but for the most part, most physicians don't do this every day, and so the number of red blood cells is going to be pretty low. It's going to be higher than the normal amount. So in the lumbar puncture, the first thing you're going to look for is the color. And the color, if it should be colorless and clear. If it's turbid, so you can have turbid, and that would indicate some type of blood cells. It could be white blood cells, or it could be red blood cells. If it's red blood cells, that's quite a bit. It would indicate a hemorrhage just based off of the appearance. If it's white blood cells, it would indicate an infection. The next thing you're going to look for is blood, and of course I just talked about that. You can also look at something called xanthochromia, and that's basically a yellow to a pink discoloration. That's from hemoglobin breakdown. And if you have that, that means that there's blood has been there for a long time, greater than 2 hours, and it's begun to degrade. So after you look at the color, the next thing you do is get out your microscope and look at the cells. And an increased number of white blood cells could indicate an infection or an inflammatory non-infectious process. So let's just talk about what kind of blood cells we'd see. If we see neutrophils, so I'm going to say neutrophils, that would indicate bacteria, right? And then if we saw primarily lymphocytes, that would indicate a virus. And if we saw eosinophils, what do we have left? We have fungus and parasites. So those are your the basic breakdown of cells and what they would mean if you found them. Next, you're going to look at the glucose in the CSF, and if you have a lower than normal glucose, well, first, what would normal be? So usually the blood to CSF ratio is about 6. So there should be 6 times more glucose in your blood than in your CSF. And if it's more than that, that could mean problems. If it's less than that especially, it indicates some type of infection, a non-viral infection. If the CSF glucose is less than 18 milligrams per deciliter, then that is highly suggestive of a bacterial meningitis. The next thing you look at is proteins. So proteins, normally proteins would be between 23 to 38, so just think 20 to 40. But if you have a bacterial infection, you're looking at 250 plus, so bacteria. And if you have a viral infection, you're looking at around 150. So protein is going to be highly elevated in either case. And now that we know a little bit about bacteria and viral, if we saw something like a low glucose and a high protein, we would definitely think bacteria. If we saw a normal glucose and a high protein, it wouldn't necessarily mean that it's viral, but it would rule down bacteria and have viral higher in our differential. Now, on the other hand, if you saw an increase in proteins, but you didn't see any increase in white blood cells, that would rule out a virus. And so we've actually, that's what we found in our lumbar puncture. We saw that the white blood cells were not elevated, but the protein was. We also saw that the glucose was normal. So we've ruled out bacteria, we've ruled out viral, and now we have this thing called albuminocytologic dissociation. Now the albumino part is referring to protein. So the protein went up, but the cytologic is referring to white blood cells, and white blood cells remained even. So I'll use a sideways arrow to indicate that it remained even, it didn't go up or down. So this dissociation means that it's not viral, it's not protein, it's not bacterial, it's not viral. And this usually indicates Guillain-Barre syndrome. However, it's not diagnostic. At this point, we'd want to confirm Guillain-Barre syndrome by doing an EMG. So EMG studies would confirm our diagnosis. However, in our case, our patient said, no, I'm not allowing it. But she was determined to be not capable, not having a decision-making capacity. And so the mnemonic you want to remember for that is curves. And this will probably be good for the IPC portion of the test. And so curves is choosing and communicating. and understanding, reasoning, value, emergency, and surrogate. In our situation, because our patient was only oriented to person, she wasn't oriented to place or time, she was deemed to be incapable, incapacitated for decision making. So we're going to do an EMG and we're going to do a nerve conduction study. And we're going to get permission from a surrogate. It's important to remember that competence is determined by a court, and capacity is determined by a doctor. You're going to be a doctor. You will determine capacity, hopefully with some variation of the curves mnemonic. So with the nerve and muscle studies, what we're going to see, so you want to distinguish between neuropathy and myopathy. And so with neuropathy, what you would see is fasciculations and fibrillations. So it's fasciculations and fibrillations. So a fibrillation is a spontaneous twitching of a muscle that's been de-innervated, and a fasciculation is like the visible sign. So if it's just a single fiber, you're not going to see it unless you're using an EMG. If it's a fasciculation, it's multiple fibers kind of doing it just enough that it's visible with the eyes. It's important to note that fasciculations are not always pathologic, fibrillations are. Now the motor unit will also have decreased amplitude, but it'll have decreased activity, but normal amplitude. With a myopathy, the motor unit activity will be normal, but you'll have a decreased amplitude. So in our nerve conduction study, what we saw were fibrillations. We also saw positive sharp waves. And these are both indicative of denervation. Now with the nerve conduction study, the two things you're going to look for is if you have a myelin disorder or if you have an axon disorder. With myelin, you're going to have reduced velocity. If you have less myelin, myelin increases velocity, so reduced velocity, but normal amplitude. And with an axon disorder, you're going to have normal velocity and a reduced amplitude. The other thing we want to note about the nerve conduction study is something called an F wave. An F wave, I think of it like bouncing a ball off of a wall. So if here we have our nerve end plate and the muscle would be over here, we have our long axon going back to the cell body. So here's our cell body. If we were to stimulate the nerve right here, there's nothing that would stop the action potential from moving in both directions. We typically think of an action potential as being unidirectional, that it starts in the body and it goes to the motor end plate. And that's because whenever you stimulate something right here, it'll stimulate here and these will be turned off. And then these will be turned off and these will be turned on. It'll go to here, these will be turned on, these will be turned off, and it keeps going. But if you started it right in the middle, this is not turned off yet and this is not turned off yet. So it'd move this way. This would become turned off. It would move a little bit further. These would be turned off. These would be turned on. It would keep moving this way. Once it reaches the cell body, sometimes it will move back down to the synapse. And so at that point, you'll have the regular wave coming down stimulating the muscle. Then you have this other wave coming up and coming back down and stimulating the muscle a little bit later. That's called the F wave. The F wave can be absent for a lot of reasons, but the main reason would be if you have some type of damage. It would be proximal to the cell body. So any type of damage between here and the cell body would cause an absent F wave. What we saw in our nerve conduction study was evidence of both demyelination and axonal damage. Let's talk about the complications that came up in this case. First of all, in a paper written by A.J. Scott, R. Duncan, and L. Henderson, rhabdomyolysis may be associated with Guillain-Barre syndrome. Now, typically what happens is the muscles will be damaged. Muscle damage is due to denervation. So you can leak out creatine kinase from the muscles when they're denervated. Now, sometimes the denervation is not the cause of the increased creatine kinase, and just rhabdomyolysis, it just occurs spontaneously. And the exact pathophysiology at the time this paper was written was not known. So what exactly is rhabdomyolysis? So the first thing you need to know about it is that it's damage to the muscle, and that damage to the muscle causes it to release creatine kinase, and it also causes something similar to third spacing, where water moves in, so fluids move into the muscle tissue, into the tissue. I'll just write tissue. And this can cause a couple of things else to happen. So the complications with rhabdo would be hypotension, and it would be reduced urinary output. And what you're going to get is an increase in creatine kinase type MM. You're also going to get an increase of myoglobin, and with that you'll see some electrolytes coming out. So you'll see potassium, calcium, and you're also going to be able to diagnose this through urinalysis, because in the urinalysis myoglobin shows up as blood, but when you look at it under a microscope you see that there is no blood there. So that blood on the dipstick, it usually will detect hemoglobin, but hemoglobin and myoglobin are so similar that they both show up, and so whenever you see that there is no blood in the urine by looking under a microscope, you know that the blood detected was not really blood, it was myoglobin, indicating muscle damage. Now, another complication is because you have a reduced renal blood flow because of the hypotension, you're going to get death of the epithelial cells. So the kidney epithelial cells within the tubules. So these are tubule epithelial cells. And whenever you have death of the tubule epithelial cells, that's known as acute tubular necrosis. Whenever you do a urinalysis, what you're going to see are granular casts. And these granular casts, if they're described as muddy granular casts, that's pathognomic for acute tubular necrosis. So just remember muddy brown casts, and that's acute tubular necrosis. So now we've went basically through the case. I didn't cover any of the pharmacology. Again, that's going to be in my pharm cards posted on Quizlet. What I want to do is look at a few other things to do specifically with Guillain-Barre syndrome. For example, the epidemiology. We'll just cover some of the important highlights. So it's about 2 people in 100,000 get this. It's caused most of the time by molecular mimicry. Molecular mimicry. And that's whenever you have an infection with Campylobacter jejuni. And I know this is supposed to be lowercase, don't slaughter me for it. And whenever your body starts attacking Campylobacter jejuni, it has some very similar proteins to what's seen on Schwann cells and on the axonal membrane. Now, it can be associated with other infections. It's most strongly associated with the Campylobacter infection, but things like HIV can also produce this autoimmune disorder. It has an incidence somewhere between, for the male to female ratio, it's somewhere between 1.3 and 1.5 to 1. And that should actually be a colon. So 1.5 to 1 male to female ratio. It can start at any age, but typically it has a bimodal pattern, so there's a peak between ages of 15 to 35, and then there's another peak between 50 to 75. Now let's talk about the clinical presentation. So here's my man. He's got Guillain-Barre syndrome. And what happens is, if you're attacking, let's suppose that you are shooting at nerves. You can shoot here, you can shoot again right here, you can shoot again right here, you can shoot again right here. And so what you're noticing is that the farther the nerve travels, the more often it can get shot. So what I'm trying to say is you're going to get bilateral weakness, and it's going to typically start at the more distal areas where the nerves have to travel the farthest because they have more opportunity to be damaged. And it's also going to present as a lower motor neuron symptoms. So things like flaccidness, weakness, hyporeflexia. And the disease moves really fast. It will be 2 to 3 days at most. You're going to go from the onset to extremely weak, almost unable to stand up. On some occasions, you're going to get autonomic involvement. So you can get dysautonomia. And unlike some other causes of weakness, you're going to have very little muscle atrophy. So I'm going to put no atrophy. This would distinguish the cause from something like ALS. Now the treatment for this, is typically you can either choose IV, IG, or plasmapheresis. So plasmapheresis. And your choice should probably just be based on economics, because one is not better than the other. These two are equal treatments, but they're not additive. So if you choose IVIG, doing plasmapheresis will not improve things. If you do plasmapheresis, IVIG will not improve things. They will both work exactly equal to the other, but neither one is better than the other, and you can't add them together to get a better result. Now just a quick note, plasmapheresis is the same thing as plasma exchange. Now further to note about the treatment is you're going to be stuck in a bed for quite a while because you're not even able to barely lift your arms at the worst part of this. And so you're going to have DVT prophylaxis. And this will usually be heparin. But you remember, so in our case, something I didn't mention is that we got heparin-induced thrombocytopenia. And so we had to change our treatment to argatroban and enoxaparin. It's very common to get respiratory involvement, so you're going to start, possibly if you diagnose this early enough, you're going to want to do some type of pulmonary function test and be ready to use some type of ventilation. whenever the pulmonary function is reduced. Remember, you can get rhabdomyolysis, and that can cause bladder problems. So you're going to want to you want to watch the bladder, watch the urine output, and make sure you just do bladder care, bowel care, and treat any pain that might come up. Now, whenever you do ventilation, there's always a risk for ventilator-associated pneumonia. And from that, it's really easy to get sepsis. If you get sepsis, you can get septic shock, and this is going to add to the hypotension, the decreased renal perfusion that you got from the rhabdomyolysis. So you'll treat that specifically with dopamine, because dopamine will increase renal perfusion, renal blood flow, while at the same time constricting other vessels because of its alpha-1 activity and increasing the heart rate and inotropy. Last thing I want to do is go over a few of the questions that were asked in the case that I haven't specifically covered yet. So the first one is, what are the criteria for successful extubation? So criteria for extubation. And I just want you to think, when they extubate, they have to be able to breathe. In breathing, there's evidence of breathing if they can cough, right? So if they can cough, they can breathe. So I want you to remember the mnemonic cougher. Are they a cougher? Specifically, what this means is that the cause for them to be intubated is taken care of. The oxygen status is, specifically the SpO2 needs to be greater than 90%, and when the FiO2 is less than 50%. The pH needs to be taken care of, and so it needs to be greater than 7.25. They need to be hemodynamically stable, so hemodynamics, and specifically the blood pressure needs to be between, the systolic blood pressure needs to be between 90 and 180. They need to be able to have inspiratory force by themselves, so can they initiate inspiratory effort? And lastly, they need to be responsive. And so that means that they need to be alert. Then there was another question about the safe removal of a chest tube. And so we're going to look at that as well. So chest tube removal. And so the first thing is the cause is taken care of. The second thing is that they can fully expand their lungs. And the third thing is they need to have a pleural fluid output. So fluid in the pleural cavity has an output of less than 200 cc's per day. And lastly, there should be no air leak. I also want to clear up one thing that I wasn't completely clear on with Guillain-Barre syndrome. There are multiple types. There is the two main types, which is an acute, and that's supposed to be an A, acute inflammatory demyelinating polyneuropathy, and there's an acute motor axonal neuropathy. This accounts for about 80 to 85% of cases, and this accounts for about 10 to 15% of cases. These are the two main ones, but there are about 10 other subtypes as well. And we saw that even in a demyelinating polyneuropathy, just like we had, it can progress to becoming an axonal neuropathy as well after time goes on. And in that case, it would be some other subtype that we would look at and diagnose.